to this first session, Special Topics in Geriatrics, Healthcare Reform. And my name is Tony Denuzzo. I'm the director of East Texas Geriatric Education Center. And I really have been looking forward to getting this started for quite a while. A lot of work's gone into it. But I want to just talk a little introduction in terms of how things are going to be set up. We're going to talk a little bit about the CE that we're offering. But this is sponsored by the East Texas Geriatric Education Center Consortium. We've been together as a GEC since 2003, have put on several of these kinds of series, and I see a lot of familiar faces, which is always nice. Can everybody hear me okay? I'll try to remember to keep this up over here a little bit. Okay, I want to also acknowledge our partnership with the East Texas AHEC. We are a large group. We have a large service area that covers 5 AHEC regions in East Texas, and we have coordinators from AHEC in each of those regions. And without them, there's no way that we can communicate as well as we try to do to our large service area. The ETGCC is funded by HRSA, and this is our first year in our 3rd cycle of funding, and we'll have another 5 years of doing these kinds of things, which I'm real happy about. I'd like to also tell you a little bit about the agenda. Okay, you should all have handouts, and this will have the slides and everything that you'll need for today. But after my introduction, I'll be introducing Laura Hermer, who'll be talking for about an hour and a half to 2 hours on healthcare reform, the road from here. It'll be the overview about healthcare reform. And then we'll have a short break, and I'm sure there'll be restrooms and people to direct you towards wherever you need to go. And then we'll have about an hour presentation by Dr. Howard Brody. It'd be really important to take time to fill out evaluation forms so that we can improve what we do and get some feedback from you about the session. Not just about the quality of the speakers and everything that was done, but also the environment, because we want to make sure that we're doing a lot of different things with teleconferencing, and how we work all this and get feedback is real important. Okay. As I said, this is a series on healthcare reform that will be 4 sessions on the 3rd Wednesday of each month, except in March, which is spring break. So we're skipping March. Next month, in February, we're going to have a 2-hour session on the impact of healthcare reform. I'm not really sure if that's going to be a webinar yet. I'm working on that concept, because I really would like a lot of feedback, question and answers, to get an idea of what people would like to know about healthcare reform. In April, we're going to have a panel, an in-professional panel, looking at standards of primary care of older adults. And that's always very interactive and very informative. And finally, in May, we're going to have a session to look at, like, okay, so where are we going with all this? And hopefully wrap it up. And by then, everybody will be complete experts and know everything there is to know about healthcare reform. Right. Okay. Okay, before I get into this, I am going to attempt to bring in our sites from our other locations. No, that's not it. I'll try that one. There we go. Okay, we have with us today, this is Baylor University in Waco, as part of the Brazos AHEC region. Let's see, right up here we have Victoria College as part of the Pecan Valley region, AHEC region. Below them, oh, they're switching on me. SFA was here. Okay, this looks like Weatherford College in Decatur, and that's part of Prairie AHEC. Now it's Lamar University in Beaumont. That's part of Coastal AHEC. And I think, okay, SFA, Weatherford, Lamar, Baylor, and I'm sorry, Pecan Valley, Victoria, this is Weatherford. So there we are. Okay, we are offering continuing medicine education credits for MDs, DOs, and nurse practitioners and physician assistants. We are approved for 3 hours of credit. And all what you really need to do is make sure you sign in and complete the evaluation form and the credit request forms that are in the back, and we can help you with all that. In around 6 weeks, we hope to get you your certificates for your 3 hours for CME. We also have social worker, CEUs, and also this is also approved for 1 hour ethics credit and 0.1 hour social worker ethics credits. For CNE, for nurses, we have 2.66 hours, and we have a separate sign-in sheet for all those that would like to have CNE credits. And this is through the Texas Nursing Association, so they're about the best you can get for CNE. Okay? But you have to be present for the entire session, also complete your evaluation forms, and hand those in to me or some other people that will be roaming around to help you. Okay. We also have CE credits for physical therapy and occupational therapists. It's approved for 3 hours CE. The physical therapy is pending, but we won't have any problem getting that. We do it online. It just takes a little while for it to go through, but we've been doing it for years. All right. Is there any questions regarding the CE or anything? Okay. Before I introduce our speakers, I'd like to say that none of our speakers, Dr. Hermer or Dr. Brody, have any commercial affiliations to disclose. Okay. All right. Dr. Hermer, she received her JD at the Northeastern University School of Law in Boston and her LLM from the University of Houston School of Law. She's a healthcare attorney and policy analyst who specializes in the issues impacting access to health care in the U.S. She served as a research professor at U of H Law Center and researcher in the Department of Health. She's currently assistant professor for the Institute for the Medical Humanities at UTMB. Professor Hermer's areas of specialization include law and policy of private health coverage, Medicaid, whatever SCHIP is, which we'll hear about, SHIP, okay, health coverage expansion proposals, medical malpractice, bioethics, and of course, the law. So without further ado, I'll get Dr. Hermer.
Okay, thank you very much. Can everyone hear me all right? Great. It is so good to see you all today. I was concerned that this might not be quite so well attended, and this is wonderful to see so many people out, and good as well to see the people at the off-site locations. Now, today I'd like to talk with you about health reform, specifically in the context of the elderly and the implications for the elderly and for people who care for the elderly. If you have any questions while I go along, this is a very long presentation, and I can sit up or stand up here and I can talk and I can talk and I can talk. It will be more interesting if you all have questions or comments, if you could chime in to the extent that that's possible, given also the technological issues involved. I will also have a time for questions between each section and then also at the end. So I'd like to summarize the present healthcare system in this talk, and the reason that I am going to look as well at the present healthcare system and not just at health reform is because health reform builds so much on the present system. You need to understand what's going on now in order to understand what we have under health reform. And so then, of course, talk about what PPACA, or the ACA, the health reform law, does to the present system and evaluate changes for the elderly and their caregivers. And I'd like to discuss Medicare, Medicaid, long-term care, and more peripherally, private health insurance. So just to briefly start, this is coverage in 2008. This is data from the Kaiser Family Foundation. You may be familiar with the Census Bureau data that came out last September, which is slightly different. The uninsured, of course, that number has increased. The number of people with Medicaid has increased. But this is roughly the breakdown of the different coverage forms and the lack of coverage that we have in the US. And you can see that when you break it down by payment, you come up with a slightly different configuration. Medicare, of course, is more expensive. The elderly are a much more expensive population to care for. So this is not surprising. Medicaid and CHIP as well is increased. And then there's a substantial out-of-pocket amount there as well. Now, of course, we have a largely private, it's a public-private system in the US, but just to compare it with other OECD, the Organization of Economic Cooperation and Development nations, these are the more developed nations, and you can see the breakdown by public, private, and out-of-pocket expenses. The US, we are at the top. This is 2005 data. At that time, it was about $6,000 per capita. Now it is $8,000. 2011, about $8,000 per capita in the US. And you can see that we have a lot of out-of-pocket expenses in the US. I think it's only Switzerland that surpasses us in that regard. And it's somewhat of an anomaly how we ended up with our present system. And just to very briefly go over the history, we ended up with a private system in large part because of a historical accident. Private coverage came about in the earlier part of the last decade, and it only really started to become instituted through employment and more often offered through employment during World War II, when there were wage freezes and employers were enticing scarce employees to come work for them by offering more generous benefits, including this new health insurance. We have some public coverage, of course, through Medicare and Medicaid, which were enacted in 1965. And these covered populations that are poorly reached by employer-sponsored coverage. One other thing about employer-sponsored coverage, it is heavily subsidized by the federal government. We get a substantial tax exemption with private coverage, and so we don't pay taxes. For those of us who have coverage through our employer, we don't pay taxes on the value of that coverage, and that foregone revenue is at least $250 billion per year, and that, of course, also goes up as coverage costs increase. There are a number of problems with our system. We didn't reform health care, or we didn't reform health coverage just because we didn't have anything better to do in the Congress. There are numerous problems. Cost control is a perennial issue. It goes up at roughly double the rate of general inflation. And this has been a trend for decades. You go back to like the 1970s, and this has been a continual trend. We've got different payers. We have a very fragmented system, and so. The cost of health care, as I mentioned before, with, for instance, the subsidies that we have for private coverage, a lot of what we spend for health care and health coverage is masked. It's very difficult to ferret out what those costs are. And it is difficult even if we're talking about nitty-gritty costs. And so if you call up the hospital as a patient and say, look, I'm thinking of having gallbladder surgery, and can you please tell me what it's going to cost if I get this done? You're going to end up having a very hard time figuring out what those costs are going to be. They're probably not going to be able to tell you. There was also an issue when Medicare and Medicaid came about in 1965. They were based on the Blue Cross Blue Shield system. It's a fee-for-service system. And since physicians and hospitals and other providers would be paid based on what they performed and for the reasonable and necessary expenses of what they performed, costs were going up. And of course, there were other things going on. Medical technology was also increasing dramatically at that time. So a number of other issues. But healthcare inflation really became an issue at this time. And ultimately, we instituted the DRG, the Diagnosis-Related Group System for payment for hospitals, and then the RBRVS, the Resource-Based Relative Value Scale for physicians for payment for Medicare. And so we have prospective payment rather than retrospective payment for hospital care, trying to keep costs in check. Another major issue that I'm sure many of you are aware of is that there's a great disparity between what different health insurers pay for services. And so if you see the same patient with, or the same type of patient with the same type of condition, but one has Medicaid and the other one is insured through Aetna's PPO, you're going to get paid very differently for providing exactly the same service. And so this has also been a major problem. Then we have the delivery system, which is highly fragmented. There are, as many of you are aware, particularly at our offsite locations today, in rural areas, we have a problem of underservice. Some areas are, on the other hand, over-provided. We have more providers than technically we need, quote unquote, in that particular area. There are issues with quality. So I'm sure everyone is familiar with the Institute of Medicine report in 1999, To Err is Human, looking at excess morbidity and mortality associated with hospital care, deaths that ought not to have happened, morbidity that ought not to have happened. And these problems still exist today. And PPACA makes a strong effort to try to deal with some of these quality issues, and we'll be looking at that in a bit. Then we also have uncoordinated service, and so we have a big push now for electronic health records and trying to defragment care. There are a number of other ways through health reform that we are trying to defragment the delivery of health care. So there's also the problem of coverage. So many Americans fall through the cracks. According to the Census Bureau, about 16.7% of Americans are uninsured now during the economic downturn. So there's the one prescription for dealing with that. But only about a little less than 2% of Americans age 65 and older are uninsured. The problem is that they all have Medicare, or many of them. Most Americans age 65 and over have Medicare, not all of them, but most. But it doesn't equal full coverage, and there are many, many gaps in Medicare coverage. And so now we have health reform. And this is intended to increase and stabilize coverage, and also to improve the quality and delivery of care in the US. The senior population, however, is not so convinced that health reform is going to be a good thing for them. And you can see that there is this declining percentage here for the number that we've got favorable here. We have unfavorable, and then we have the undecided is increasing. But you can see unfavorable is around 35%. And this is what many of them are worried about. They're worried about the decrease in Medicare reimbursements, and that this is ultimately going to impact them adversely. And this is a real issue that we need to deal with. So let's start with Medicare. And I'm sure most of you are familiar with Medicare and the Medicare program. It covers the elderly and disabled population. It has 4 parts. And it's also an entitlement program, by the way, for the people who pay in to Social Security for at least 40 quarters, so essentially work full-time for 10 years in whatever form. They are entitled to Medicare. They have hospital insurance, physician services, and this is traditional Medicare. This was the original portion. Then there's Medicare Advantage, that's Part C. And that's the private insurers who are now involved in the program, and that's a growing trend. And then there's Part D with the prescription drug program that was instituted in 2003. Now, for Parts A and B, I mean, these numbers change usually yearly. They've stayed relatively flat for the past couple years. For Part A, if you qualify for Medicare, you don't need to pay any premium to get this. You qualify. You need to pay a deductible. This covers hospital costs. Once you pay the deductible, then covers your hospital costs up through day 60. From days 60 through 90, then you have a copayment, and the copayment becomes fairly substantial. And if you exceed that, and some people do, then you have a lifetime reserve, a set of lifetime reserve days that are even more expensive. But once you exhaust those, it's done. There is not Medicare catastrophic coverage. Part B deals with physician costs, and the premium, there's a premium for it. You can opt to take it. You don't have to. It works out where the government covers about 75% and the person who is insured covers about 25%, and that portion rises per year. If you are a higher income individual, it's about $85,000 for an individual, $170,000 for a family or a couple here, then you pay more, and that's on a sliding scale going up to $369 in 2010. And there's a deductible, and then you pay 20% of the costs on top of that. Medicare Part C, the Medicare Advantage program. It's a private plan option. They have to offer all the traditional Medicare benefits, but a number of them offer more. A number of them offer more than that. And this is a big selling point for them, particularly before prescription drug coverage came into effect. It was a very big selling point because some of them would cover prescription drugs. They can impose additional cost sharing. That is going to be limited under PPACA. And they contract with providers separately from traditional Medicare. And so just because you are a traditional Medicare provider does not mean that you are contracted with any Medicare Advantage provider. And you often have networks of providers in the Medicare Advantage programs. They're often managed care plans. So reimbursements have been fairly substantial under Medicare Advantage. And you can see if the cost of care for traditional fee-for-service is at 100%, oh dear, and these didn't show up. Okay, so you've got, on average, reimbursements have been about 114%. So the cost of care is about 114% of traditional Medicare. And these, for some reason, this did not show up. But this, for example, is, I believe, under the Medicare PPOs. And here are the private plans. There are also Medicare Advantage private plans. And so you can see that they are universally higher, even the HMOs, higher than traditional fee-for-service Medicare. And under health reform, those fees are going to be declining. And there was a prediction that even starting in 2011, you would start to see a flight of programs from Medicare Advantage. This is not what has happened. This is not what has happened. The Medicare Advantage program looks solid for 2011, and there are more participants than there were before. Medicare Part D, the prescription drug program. When Medicare was enacted in 1965, prescription drugs were just not a big deal. Now, of course, they are. So we have this very, very strange benefit design. You'll see there's, oops, I'm sorry, there's this out-of-pocket cost. So you have your deductible, $310, and these numbers change every single year. And then from here to here, from $311 through $2,840, the prescription drug plan, and by the way, you're paying a premium for this, pays 75%. Your costs, the subscriber's costs, are 25%. Then you come to what's called the donut hole. And in the donut hole, the subscriber is responsible for 100% of their drug costs, and they're still paying their premium, but they're responsible for those costs. And for the very unfortunate about 5% of beneficiaries, most beneficiaries do not hit the donut hole, but a large minority do. About 5% get catastrophic coverage. And so if they have more than $6,349 in prescription drug costs, then the prescription drug plan pays 15%, the subscriber pays 5%, and the federal government pays the remaining costs. Do we have any questions or comments or anything so far? Yes?
So many acronyms. What is PDP?
The prescription drug plan, yes. Yes, and of course there are going to be more acronyms throughout. There is an average of about 33 plans per subscriber, so you have a choice among plans. And these are plans, by the way, that didn't exist before 2006. They did not exist, and now we have a plethora of them. The average premium for 2011 is about $40, and it's available as a standalone if you have traditional Medicare or as part of your Medicare Advantage plan. The federal government may not use its purchasing power to hold down drug costs. And that is that was part, it was an express part of the original statute. So you can see who has coverage or how people pay for their drug plans. And so you have a large number with a standalone prescription plan and Medicare Advantage plan. And so this total Part D plan is about close to 60%. Then you have retiree drug coverage, so the former employer pays for it. And you've got other drug coverage, and an unfortunate number who have none at all. So we have changes in PPACA. Okay, it does not cut eligibility or services for beneficiaries. And the law, you can go through in section after section dealing with Medicare, and it says no cuts, no rationing, no. You cannot pay for it this way, and we're not allowing this to happen. It also, by the way, does not create death panels, and this is not being facetious. Back in July of 2010, in a Kaiser poll, found that 36% of seniors thought that Medicare created these death panels, and there's the data. And so this is what people were thinking. And this is a real worry. So that is not in PPACA, okay? New Medicare benefits, it eliminates the Part D donut hole. And this is gradual. It happens over time. And so there was a rebate, a $250 rebate in 2010. There's a 50% discount on brand name, not generic, brand name drugs for this year. And the coinsurance is going to start declining. And this is going to gradually reduce to 25% by 2020 so that it is identical to the rest of the plan. And it will save an estimated $43 billion for beneficiaries. Yes?
How do you get a 50% discount if the government didn't use their buying power to increase?
Well, they're not purchasing anything for this. These are all through private drug plans. There is no public drug plan per se. The federal government heavily subsidizes the drug plans. And what they did when PPACA was being discussed and when it was being debated, the pharmaceutical industry said, look, here's what we will chip in. Here's what we will chip in. Here's part of the deal. And so this is part of the deal. And And then also for preventive services with an A or B rating are now covered starting this year with no cost sharing. So starting January 1st of this year. And this, so this is now in effect. Also, we have the Center for Medicare and Medicaid. Yes, I'm sorry.
What are some examples of preventative services? Like colonoscopy?
Like colonoscopies, like mammograms, like, for example, your physician discussing, or a physician discussing smoking cessation with a patient. Those would be examples of preventive services. So then we also have the Center for Medicare and Medicaid Innovation, and the task, as Don Berwick said, is to explore new approaches to the way we pay for and deliver health care to patients so that we have better results, both in terms of the quality of care and the affordability of coverage, by identifying, testing, and ultimately spreading new ways of delivering care and new ways of paying for care. So we already have a way of testing demonstration plans in Medicare and in Medicaid. And so states can apply for waivers from certain federal rules. And we've had this for a very long time. But the CMI, their task is to look at this in a more systematic fashion so that we can really put into effect what we're testing, if it is working. A problem with a lot of demonstration programs is that, yeah, maybe they work well in this particular state, but a lot of times it's just a flash in the pan. It doesn't really get evaluated quite as well as, or quite as rigorously as one might like. States are required to put in information to CMS about how their demonstration plan is working, but it doesn't always get disseminated as well as one might like. So there are a number of pilot programs that PPACA establishes that are going to be tested under CMI. And this is just among what will be tested at CMI. So we'll have accountable care organizations, and I'm going to go over each of these in turn, by the way. Payment bundling, the independence at home demonstration, and then also a hospital readmissions reduction program. And these have already, these are going to be starting. I think the independence at home actually technically was supposed to have started, except the call for proposals has not yet gone out. So that's an issue. Accountable care organizations. You have different groups of providers, different types of providers who band together to provide care, total care for the patients in question. These have to be large organizations. They have to be able to service at a minimum at least 5,000 Medicare patients, at least 5,000. And any shared savings as a result of what they're doing, they're going to be responsible for the quality of care and also for the costs of care. And it's uncertain exactly how they're going to be paid. There's a provision for providing them the way that traditional Medicare does, but then also there's a provision for partial or even full capitation for the patients. And if they save money, then they will share those savings among the different providers. And so hospitals in particular are expected to be organizing these accountable care organizations. I understand UTMB is thinking about that from Dr. Callender's address a few weeks ago. And you can also have group practices. You can have a network of independent practices in more rural areas. And these are entities that could form an ACO. There's also going to be a payment bundling demonstration. And the Centers for Medicare and Medicaid Services, they're going to be looking at up to 10 conditions. They're not selected yet, to the best of my knowledge, at least. But up to 10 conditions for which they're going to bundle payment. And so there will be one payment for all care provided 3 days prior to a hospital admission and 30 days after. And that will be both inpatient and outpatient hospital care, physician care, home health care, skilled nursing facility care. For all that care, it will be bundled. And this, again, I am not certain how this is going to work out with respect to paying the money to the different providers involved. I have not seen yet how that is going to work. Then there's the Independence at Home demonstration. Yes?
How is that different than DRGs? I mean, wasn't that the kind of philosophy behind that?
The DRGs cover inpatient hospital. They cover just hospital care. And so physician services, no, not involved. For the skilled nursing facility, it's not. So yes, good question. Independence at home. So it's delivery of primary care at home to Medicare beneficiaries who have 2 or more chronic conditions. And it utilizes a primary care physician or a nurse practitioner or physician assistant, and they lead teams to provide care, so they need to be available 24/7 for these patients. And it's intended to reduce avoidable hospitalizations, emergency room visits, and so forth. And patients must elect to participate in this. This is not something that Medicare beneficiaries are going to be put into whether they want to be there or not. So they can choose to participate in this. And these teams, I believe they need to be able to service at least 200 patients. And so it's, again, a larger group here. And then there's the readmissions reduction program. And it's providing for reduced payments for so-called excess readmissions. And so they're going to be looking at readmissions for particularly voluminous conditions that the hospital sees quite a lot of, or very expensive conditions. And to the best of my knowledge, these also have not been designated yet. They're going to be starting with 3 and then moving on from there. There's also the Federal Coordinated Health Care Office, and this is to better integrate care for dual eligibles, for people who are eligible for both Medicare and Medicaid, usually very frail, sick, often elderly or disabled population, and also to get out better information to beneficiaries and to people who qualify but may not have signed up for the program, just about what benefits are available and how to get that. And this is newly established within CMS. Of course, however, the piper must be paid. And PPACA takes a lot of money from Medicare. It can. And so this is what's going to be happening. First, for beneficiaries, there will be a cost increase without a so-called cost increase. And they're doing this by freezing the rate at which, if you're a higher income beneficiary, then you need to pay an increased premium. And so instead of letting that rate, remember the $85,000 or $170,000, instead of letting that rate go up with inflation as it has been doing, it's going to be frozen at that level. And so more and more beneficiaries, Part B beneficiaries, are going to fall into that category. Then there are payment cuts. So to Medicare Advantage plans, remember the ones that are being paid an excess amount for care for the beneficiaries, those payment rates are going to be reduced. Also, hospital, skilled nursing facilities, and home health agency payments, among others, there will be others, their payment rates are going to be reduced. So when CMS determines its market basket updates, it will do that, and then it's going to cut that amount by, I believe this year it's 0.25%, and it's a different percentage up through 2019. Then there's also the Independent Payment Advisory Board. The Payment Advisory Board is it's a group of independent individuals who are charged with making cost reduction recommendations with respect to Medicare. Now, through 2019, the hospitals, skilled nursing facilities, they're already taking a cut. So the IPAB, they can't cut more through 2019. After 2019, they're in the mix. But they need to keep the costs down. In any year in which Medicare inflation exceeds the average of the CPI, the Consumer Price Index, and the medical expenditure portion of the Consumer Price Index. Right now, that's what we're dealing with. And so they take the average of this. Remember I said that the medical index is increasing at about double the rate of the general inflation. So they're going to take the average of that, and they're going to be using that as a target. And then after that, they're going to be looking at GDP growth plus 1%. So they're really holding down costs. And the cost reduction needs to be at least 0.5% for 2015. We're just assuming that, in fact, we're going to be seeing this come into effect, and it's probably a pretty good assumption, rising to 1.5% for 2018 and thereafter. Now, the IPAB cannot ration care. Now, what rationing care means is a question that is not dealt with in the statute, and it is not a term that is defined in the statute. So do they mean that they can't limit the number of services, or they can't pay for services, certain services they simply won't cover, like NICE used to be in Britain? What that's going to be, we don't know yet. But they also can't raise costs for beneficiaries, and so they can't get costs out of them. And Congress must enact these recommendations. So the worry was that, yeah, IPAB would make his recommendations and Congress would say, no way. We have our constituents that we need to worry about, and we're not, these are really perilous recommendations, we're not going to do it. Congress has to enact them, and if Congress does not, then Congress has to figure out other ways of getting exactly the same, well, almost the same, sorry, it's not precise, but essentially the same cost reduction. So an unknown regarding IPAB, how are providers going to respond? Are they going to try to recoup these costs from private insurers and from other individuals? We don't know. How are the private payers going to respond? The IPAB can make recommendations about what private insurers should be doing. They're not binding, but they can make those recommendations. So what are the private insurers going to do? And a question that is looming in people's minds is whether Medicare patients are going to become somewhat like Medicaid patients. They're going to move among the so-called undesirables because the costs are going to be so much less. The reimbursements are going to be so much less than what you can get from a private insurance company. And so these are worries, and we don't know the answers to these questions yet. Are there any questions on Medicare before I move on to Medicaid? Yes.
For the readmission reduction program, what's the break? Is there a certain number of days there has to be a break in care? They go to the hospital, they're discharged from the hospital. If they're readmitted within 7 days?
Within 30 days. Within 30 days. And it doesn't need to be a readmission to the same hospital. It can be an admission to a new hospital for a related condition. Anything else? Yes?
Maybe it's very kind of stupid question, but
it's really not.
Mine is something like private insurance. When they give you insurance coverage, they say you are insured until, say, $5 million.
Yes.
And that's it.
Yes.
And if you exceed it, you are not covered.
Yes.
Does Medicare has something like that? That you really can't pay, forever for everybody any amount of money because you don't have them.
Well,
even life is priceless, but on the other hand, you have a price for services.
Right. Yes. If you remember going back to the Part A program for the hospital coverage, under traditional Medicare, you do have limits. They will pay, without making you pay co-insurance, they'll pay for up to 60 days of hospitalization. per spell of illness. If you need more than that, then you start to have to pay co-payments, and then after you've exhausted your lifetime reserve days, Medicare doesn't pay anymore. It doesn't pay anymore. You are on your own for that particular condition. And so if you have a hospitalization that lasts for, and they exist for, you know, a year, then you're going to be on the hook as a Medicare beneficiary ultimately for that amount under traditional Medicare. So it doesn't pay indefinitely for all kinds of care. Okay. Yes?
What's like in lay terms, I guess, is the difference between the accountable care organizations that they're selling and the, basically to me, the managed care of the 80s and 90s, what's the difference in?
This is a very good question. It's going to be, yes, it's going to be, because you're putting responsibility for the costs of care on the providers. And so if you've got a very large accountable care organization that, say, is hospital-based, and you're dealing with many tens of thousands of Medicare beneficiaries, then you're probably going to have a capitated system where the government is going to say, we're paying you X amount of money per beneficiary, and we believe that you'll be able to cover your costs, make a profit with this amount, but you're going to have to figure out how to provide care very efficiently. And if you gamble wrongly, then you're going to be in trouble. You're going to be in trouble, which happened in the 1990s. So yeah, so that's a good question, and it will be interesting to see exactly how this plays out. Yeah.
Definition how close it is, and yet nobody's saying, wait a minute, we've tried that experiment. There's
Yeah.
so many middlemen when you include this. I just didn't know if you had a different explanation.
No, there are many similarities. Did you have a?
You have not mentioned Medicare co-insurance. My wife had a lot of medical care. If she hadn't had the Medicare co-insurance,
Yes.
she would have been paying a massive amount.
Absolutely.
She complained, she's 86, and if she and her premium was $2,700 for 1 year. And she complained about that. I said, "You're lucky you got that on."
That's right. That's right. Yes, absolutely. And yes, well, but. I was going to talk about Medigap when I talked about private insurance. And so that was going to be in a different section at the top, but you're absolutely right. Medigap coverage is very important. It's very important for beneficiaries. Did we have a question from an offsite?
Yes, hi, this is Victoria. First of all, unfortunately, we couldn't hear the questions, but we do have a question.
Yes.
In our rural areas, more and more physicians are refusing to accept Medicare and Medicaid patients. What, if any, are the incentives that might change this trend?
This is an excellent question and a very timely one, given the economic downturn and the issues with state budgets right now, and with the federal budget. There's going to have to be a real look taken at disparities in payments between different providers, and making sure that the disparity is not so great that physicians and other providers stop taking the Medicaid beneficiaries and also the Medicare beneficiaries. And right now, I don't see that happening. I don't see this happening in the near future. And this is a grave problem we're going to have to worry about. Let's see. Just one more question and then we'll move on.
Could you clarify, we talk about diverse payments currently, and so for the same services. So when we talk about Medicare, Medicaid, private insured, what pays the highest benefit?
Generally speaking, the private insurers, generally speaking.
What about uninsured? I mean, the billings timing.
Oh, of course, yes. Well, the billings for the uninsured, they are billed the highest amount out of any of them, by far the highest amount. Whether the providers get paid that is quite another question, because, I mean, again, it's an extraordinarily high amount in comparison with the rates that insurers of various stripes are able to negotiate with the providers. So yes, good question. Okay. Yes?
We just make sure, from experience with this.
Yes.
Avenue, if you'll just
Restate the question. I'm sorry.
Sites can get the question, because that's what they were responding to.
Absolutely.
They can't hear it unless it comes through your mic.
Okay, sorry about that. Yes, and the last question for our offsite audience was, can you clarify the disparities between the different the amounts that different insurers reimburse, and whether the uninsured pay more or less, and how that compares to the rates for the insured?
And for those that are a little new to the room, this is like a microphone.
It is a microphone.
It is a microphone. So you can speak and state your question using this.
Okay, let me quickly move through what I have remaining here. Medicaid. This Medicaid is a federal state entitlement program for certain impoverished classes of individuals. And so you have to have both categorical eligibility and economic or financial eligibility. And it is an entitlement program because if you qualify for it under the state's rules, then you have to receive the benefit if your state participates in Medicaid, and all of them presently do. Whether or not the state or the federal government has money in the bank to pay for it. There are certain, let's see, for the elderly and disabled, generally the qualification is at 74%, people earning less than 74% of the federal poverty level. This varies from state to state. Certain states have exceptions from this. Other states allow a higher amount. And you also may be aware with the nursing home population, often that amount is substantially increased. And so there's the 300% rule. So they often qualify if they earn up to 300% of the the supplemental security income rate, the SSI rate. And then there's also a spend down program for people who have substantial medical costs, so much so that if you count those medical costs, that their income, if you subtract it from their income, that their income would then let them qualify for Medicaid. And for the dual eligibles, the elderly and disabled who qualify for both Medicare and Medicaid, Medicaid is a very important benefit because rather than having to get a Medigap plan, as mentioned earlier, you have these premiums, your Part B premiums paid for. And so for individuals who are qualified Medicare beneficiaries earning less than 100% of the federal poverty level, they get the Part B premiums and cost sharings paid for. That's covered. And then premium costs for Part B are covered for the specified low-income beneficiaries. Otherwise, if you fully qualify for Medicaid, then it acts as a full wraparound plan for Medicare. All the gaps in Medicare are covered and then some. Medicaid is an extremely important program for a number of different populations, and you'll see with the aged and disabled, Medicare beneficiaries, about 17% of Medicare beneficiaries also get Medicaid. People with severe disabilities, people living with AIDS and HIV, and then nursing home residents. One of the largest payers of nursing home services for the aged and the disabled. And you'll see that while the dually eligible account for only about 18% of Medicare or only about 18% of the Medicaid enrollment, they account for a substantial amount of the costs. And this is, by the way, 2005 data here. So they are a very expensive population. And you can see, just in comparison with Medicare beneficiaries, a very expensive population, Medicare beneficiaries, but the dually eligible extremely expensive. And a lot of this is accounted for by nursing home costs. Or other community care costs or home health care costs. There are a number of changes to Medicaid. There is a stronger focus on care for dual eligibles, and we saw a little bit of that earlier with the new center at CMS. There's a global payment demonstration program, and that's going to be for up to 5 states looking at paying for Medicaid beneficiaries, those beneficiaries who are paid on a fee-for-service basis, and that's a very particular population in many states, will be paid for on a capitated sort of global basis. And those have not gone into effect yet. CMS is going to be looking at devising quality measures for Medicaid beneficiaries, and that is under consideration now. There will be payment prohibitions for hospital-acquired infections, and they may expand those. There will be a state option to provide health homes for chronically ill beneficiaries. And then there will be bundled payments, a demonstration per episode of care like we saw in Medicare. And states will opt to do this if they want to, or they will not opt to do this. With respect to the biggest Medicaid expansion or the biggest Medicaid change that we've heard about, the expansion for all beneficiaries up to 133% of the federal poverty level, the elderly do not participate in this. It is all beneficiaries up to or just below, it is up to and including age 64. Those 65 and older, they don't qualify for that expansion. Then with the question that we had about payments for providers, this is a big issue right now. So states have a maintenance MOE, maintenance of eligibility requirement. And if they do not maintain current eligibility standards for their beneficiaries, with a certain few exceptions, then they will not get federal reimbursement for the care that they provide. They lose their federal matching funds. The federal government pays for between about, it's a differing percentage, but between 50 and about 78% of the health care costs for Medicaid beneficiaries. They would lose that. And so states are up in arms right now over this requirement. Then LTC long-term care modifications, and these will be discussed in the next section. There's also a temporary raise for primary care physicians. In 2013 and 2014, for primary care providers, they will get at least Medicare rates. Some states actually pay more than Medicare rates. If you provide care in Alaska, if you're a pediatrician in Alaska, I know we have geriatrics providers here, but if you're a pediatrician in Alaska, you're doing pretty well. But most states, you're not. And so this makes up the gap between Medicaid and Medicare rates. What happens after 2014, we don't know. It's not provided for in the statute. Is this just going to disappear? Are states going to take it over? Will the federal government continue it? We don't know. And it's federally financed. And as you know, many states have serious economic problems right now, and it's really, really hitting the fan. And providers of all different types are going to be feeling this. So both physicians and hospitals, and that payment, those payment cuts are going to be trickling down. Interestingly, I understand the Supreme Court just accepted review in a case to look at payment cuts in California to Medi-Cal, their Medicaid program, providers that were to take effect in 2008. And the Court of Appeals in California did not allow those cuts to go into effect, saying that they would unreasonably hurt care for beneficiaries because it would cut the cost far too much. And so it will be interesting to see what the Supreme Court has to say about this subject, so stay tuned on that. Any questions on Medicaid before we move on? Any questions from our offsite? long-term care, skilled nursing facility, and hospice care. Subjects that often don't receive much attention and really ought to get more attention paid. And PPACA does pay attention to them, and this is a good thing. This is paid for largely by Medicaid, out-of-pocket, OOP out-of-pocket, and Medicare. And these costs, I mean, particularly long-term care, I mean, Medicare pays for a certain amount of skilled nursing facility costs, but for the people who need long-term care is particularly problematic. It can cost about $6,000 a month to pay for long-term care. The savings rates, if you go to the www.ebri.com, the Employment Benefit Research Institute, and they track savings, among other things, savings that people have for retirement, and the statistics are scary. They're really frightening. About 2/3 of working Americans have savings of less than $50,000 for retirement. And yes, this does include the 22-year-olds in addition to the 59-year-olds, but still, it's rather frightening. And so a lot of elderly people may be in this situation, but it's difficult if this is the health that you're in. You can't be working, and you have to provide somehow for your care. So, payment for care. Medicaid is the primary provider, at least for long-term care. Not skilled nursing facility care, but long-term care. 39 states use that 300% rule that I was talking about, and so you don't have to earn less than 74% of the federal poverty level. The federal poverty level was about $10,800 for a single individual, I think in 2010. So they provide long-term care for people who are earning more money than that, and then there are various other ways to protect assets for spouses, and PPACA makes some changes to those. Medicare pays for skilled nursing facility care if needed within 30 days of a hospitalization of at least 3 days. And there is no copayment for up to 20 days. And then there's $128 per day copayment for days 21 through 100, which can add up quickly. Here are the amounts that are actually spent on care. And you can see Medicaid, while about 70% of the beneficiaries have Medicaid, the Medicaid reimbursement rates for nursing homes tend to be pretty low, particularly in comparison with reimbursement if you're paying, for instance, out of pocket, which is another substantial percentage. Medicare, because of their skilled nursing facility care, pays for a certain amount of that. And then there's private insurance, very small amount. And then home health care, again, you have Medicaid and Medicare being the primary providers. Payments by acute and long-term care, and I'm sorry, the colors didn't match up. This is the long-term care. The orange is the acute care. And you can see there is actually a certain amount of long-term care for children, a very minuscule amount. For the adults who would be getting that long-term care would be in the disabled category. And you can see the substantial differences in costs here. Long-term care changes under PPACA. There are a number of Medicaid changes, and we'll go over these in a little bit more detail. There's the community-based care enlargement. This includes the community first choice option. There's a money follows the person demonstration. There's protection against spousal impoverishment. There's the CLASS Act providing for a federally subsidized long-term care insurance for people who want to purchase that. And then also changes to hospice payment, changes to home health care payment. And also with continued eligibility for hospice. The community first choice option, this increases the federal match for home and community-based care. The federal government is very interested right now in deinstitutionalizing, to the extent that individuals in nursing homes can be taken out of the institutions and brought home or brought into the community. They're interested in making this happen. And it was very difficult under Medicaid previously, and the federal government is trying to make this increasingly easy. And so they increased the FMAP to encourage states to implement community first choice. And a state must meet or exceed their present expenditures for the home and community-based services in the first year. They must offer services statewide, so it can't just be in like a major metropolitan area, it has to be everywhere. And they offer assistance with activities of daily living and backup care, but notably it does not pay for instance, someone's rent. It does not pay for certain modifications to the home. It doesn't pay for certain medical supplies. And so this does have its drawbacks. And it applies to individuals earning up to 100% of, or 150% of the federal poverty level, and then in certain cases, more than that. Also, there's the State Balancing Incentives Payment Program. Again, a further nudge for states that are particularly behind, so to speak, in implementing community-based and home-based care. It offers an increased FMAP, so the federal match. Then there's the money follows the person demonstration. This improves on the community first demonstration. This is already, money follows the person has already been in effect. And I'm trying to remember when that was implemented. It might have been under President Bush. But money follows the person pays not only for the home-based care, but also for the rent. It will pay for modifications within the home. And so it's a very useful, but also very expensive program. And it reduces the institutional residency requirement to 90 days. It used to be that you had to be in an institution for at least 6 months. And then there's also further protection against spousal impoverishment. And so these protections that used to apply just for the spouses of people who were institutionalized, this now also applies for people receiving home and community-based services. Then there's the Class Act. And again, it's a voluntary public long-term care insurance program. And it must pay premiums for at least, I'm sorry, the people who elect this must pay premiums for at least 5 years in order to receive benefits. If there is a lapse of 3 months, then you need to correct that lapse by paying in for another at least 24 months in order to get benefits. The premiums start quite low, as you see, but they are going to be actuarially based. And so someone who's 72-year-old, who wants to buy into the program for the first time will probably be paying more than $5 a month. We don't know what that amount is going to be, however. And the benefit, you'll notice the benefit is small. It is a very modest benefit, $50 a day. So it will help defray some costs, but it will not pay for everything. Then there's hospice care. There is a 3-year Medicare demonstration now to allow hospice patients to receive Medicare services in addition to their hospice benefits. And so they can receive all other Medicare covered benefits. Also, there's going to be a reduction in payment for hospice. Like many, like hospitals are getting a reduction, hospice is also going to be getting a reduction here. Any questions on skilled nursing facility, long-term care? No? Yes?
I'll use this to repeat it.
Great.
I don't know exactly.
I'll repeat it again. Yeah.
Is this working? Yeah. I don't know exactly what they're called, but they're essentially for rich people right now, but it's where they move in, they're paying premiums. It's like a health campus kind of community kind of thing where they're paying all these premiums, and there's like a nurse practitioner and all that. But there's also assisted living, so as soon as they need help there, they move into this other section of the community. Then there's a skilled nursing facility, and there's the entire continuum all the way down to hospice, I guess.
Yes.
Is that anywhere? That's kind of what you're describing here, but I've only seen them for, like I said rich people in Connecticut. But is that
Okay.
anything, is the government looking at any of these kind of things where it's a kind of the health home, but it's the whole?
The continuum of care. Okay, so the question for offsite is whether PPACA includes or envisions in its revisions campuses, health campuses such as for the elderly, where you might start in with assisted living, or it might be a 65 and older community, and then you have assisted living, and then it moves to nursing home care, and then possibly to hospice. So as your need for care increases, the same facility can provide it. And these, I believe, and I would need to go back to be absolutely certain, I'm 98% sure that these these particular revisions under like Medicare and Medicaid for skilled nursing facility, but that doesn't really count for the whole continuum, would be included if these campuses accepted Medicaid. Yeah. Yes, is there a question off-site? No? Yes, there, please.
Yeah, on the Medicaid LTC changes, it says that assistance must be offered with activities of daily living and that sort of thing.
Yes.
Is that to be paid to, like, let's say, a long-term care facility that offers that service? Or could that be paid to a personal care home or a day program that offers that?
That would be, I mean, particularly if you're talking about the Community First program, under Community First, that's going to be paid for to the home health care provider or the different agencies that provide care to these individuals in their homes.
So it would be to a home health care?
That's correct.
Not
to a facility, it would be to a provider.
But then maybe under the Class Act,
yes,
would it be paid to facilities, or who is that? Who is eligible?
I don't know I don't know to whom those benefits are potentially payable. I recall. I mean, again, I am not 100% certain about this, so please don't bank on this. My recollection is that it can be paid not just to facilities, but also to home care providers. But if you want to get with me afterwards, I can get your email address, and I can track down that information for certain for you. Yes. Any further questions? Off-site? Okay. Private coverage. In 2009, there were about 34% of Americans who had employer-sponsored health insurance, and about 27% who had direct private coverage. And you look at those numbers and you think, my goodness, those are substantially different from the general population. But you need to understand that employer-sponsored coverage is almost always retiree health coverage. And the direct coverage, the individual coverage there is usually Medigap. That's usually what we're talking about in those cases. So here we have a breakdown of supplemental coverage among Medicare beneficiaries, and this is by income. And so people who are below the federal poverty level, notice this is Medicaid. So a huge number of them have Medicaid. A sizable number have none. A very small number have self-purchased. Some have Medicare Advantage, and a small number have employer-sponsored coverage, and you can see how this breaks down. And so here, in the wealthiest group, we have a large number with employer-sponsored coverage. There are many changes to private coverage under PPACA. I'm going to briefly go over this. This largely pertains to individuals who are younger than 65, although it also applies, of course, if you're 65 and you're still working and you have employer-sponsored coverage. So starting in 2014, coming up, there will be no pre-existing condition exclusions. So if you try to get individual coverage and you try to get, Aetna or Blue Cross, Blue Shield to give you a rate, they can't say, you have a history of cancer and we're really not interested in covering you. I'm sorry. They can't do that anymore. Additionally, their premium rating so they could say, alternatively, if there was nothing else, if they just couldn't deny you coverage, they could say, sure, we'll offer you coverage, it's $20,000 a month. They can't do that. They can't do that. So the premium rating can vary by age, region, and smoking status only. It can vary by age only by a factor of 3. Only by a factor of 3. There's guaranteed issue and renewability, so they have to provide you coverage, and if you want to renew it, they have to renew it. There will be minimum benefits and rating bands, and there will be one-stop shopping on the state exchanges. And so if you want individual coverage, and you go to the exchange, by the way, you might have storefronts throughout a state, you might be able to go online, and you can say, here's my income, do I qualify for any subsidies? And so they will evaluate you not only to see if you get subsidies from the government. If you earn up to 400% of the federal poverty level, that's about $88,000 for a family of 4 in 2010, then you qualify for certain subsidies of coverage, but also they will evaluate you to see if you qualify for Medicaid. And so the stigma of applying for Medicaid will largely, perhaps, be gone, at least with the application process. And so it's one-stop shopping. And most employer-sponsored coverage is going to be grandfathered, at least initially. And so if it doesn't meet some of these requirements, some of the requirements are, in fact, going to kick in whether or not a plan is grandfathered, but most are going to lose their grandfathered status pretty quickly. And so if they substantially increase the amount of money that their employees have to pay for coverage, for example, or if they cut benefits substantially, then they're going to lose their grandfathered status. For early retirees, until 2014, so until the exchanges go into effect, the federal government is going to subsidize early retiree coverage, which largely means that the federal government will reinsure the employers, that they'll offer reinsurance and cover up to 80% of the cost between just over $15,000 up to $90,000. And so for expensive retirees, early retirees, it will offer a certain amount of reinsurance. That is capped, but it's better than nothing. For retirees with Medicare and private, or the employer-sponsored coverage, PAPACA really doesn't say anything about it. Doesn't treat the issue separately. Of course, the Prescription Drug Act of 2003 pertains, and so a big worry with the Prescription Drug Act was that it was going to crowd out retiree coverage of prescription drug benefits. It was a big, big worry. Everyone thought that this was going to happen. The many health policy analysts, it did not. Surprisingly, it did not. The federal government offers a certain subsidy for employer-sponsored drug coverage, and that was, it seems, enough to keep it in place. Medigap, it does not address Medigap plans other than to direct the National Association of Insurance Carriers to update the benefit packages and include perhaps nominal cost sharing for physician services. Now, otherwise, it really doesn't address Medigap. But as we discussed earlier, Medigap plans are crucial. They're absolutely crucial in, for Medicare beneficiaries who have traditional coverage. Any questions on private coverage? Yes?
Maybe it's coverage, maybe it's about the payments, really. You addressed this problem before, talking about services and that they have side value. Mm-hmm. Yet when the insurance or private insurance are paying, many times say, I got a bill for $50,000 for a procedure. Mm-hmm. Yet the Aetna paid only $5,000 and everything was fine, everybody is happy after my deductible. How come those differences exist? And how come we are not able to say this service is so and so, or
This is-
this and this, and this will be addressed to Medicare patients, to uninsured, to Aetna, whatever.
Absolutely. So the question for the offsite audiences is, why don't we have just one rate that we pay for a given service? And this is an excellent question. I mean, it gets down to the heart of the question. I mean, how do we pay for healthcare services? How do we make sure that people are not discriminated against based on the type of insurance that they have? How do we make sure everyone gets the care that they need? And how do we make sure that we're not over-providing services? So not just under, but also over-providing services. The short answer is we would need to have a national fee schedule. Right now, I would guess that this is not politically obtainable. But I'm also not sure that we are moving, or that we're going to be continuing or trying to continue with the fee-for-service system in the long term, which is what such a fee schedule would imply. It's certainly one way to do it, but I'm not sure that that's what we're looking at least in the near term. Any other questions?
Okay, many of you know Dr. Brody through his news columns and just his reputation for having very thought-provoking ethics discussions. But Dr. Brody received his MD degree in college in human medicine at Michigan State University and PhD in philosophy from that same university. After completing his residency in family practice at the University of Virginia Medical Center in Charlottesville, he returned to MS State University, which he served as University Distinguished Professor and Director of Center for Ethics and Humanities from 1985 to 2000. In 2006, Dr. Brody became Director of IMH, the Institute for Medical Humanities here at UTMB, and the John P. McGovern Centennial Chair in Family Medicine. He's the author of several books listed there, and is also well known for over 125 peer-reviewed articles. In 1995, he was elected to the Institute of Medicine of the National Academy of Science.
Okay, well, thank you. Thanks very much. This is going to be a little change of tone here, I think, in this presentation. First of all, I think you can see how fortunate we are in the Institute for Medical Humanities to have Professor Hermer with us to keep us updated on these incredibly complex topics such as health reform, and to go over these kinds of details in such a clear and straightforward way. And you could also see how lucky our medical students are that she's the director of the theme on economics and policy, so she spends a lot of time educating our medical students about this. Now, you'll have noticed that Laura did a super job, I think, of being very even-handed and dispassionate in terms of saying, here's the facts. I'm not going to take a position on this. I'm just going to tell you what the facts are. I'm going to do something rather different. I'm going to very much take a position, and I will invite you to critique and to challenge the position. I will try to give you the reasons why. So I hope you'll find that the position is not just thrown at you, but it's backed up by some reasons, and I want you to go home and think about the reasons. I do expect a number of people will disagree with what I say, but it'll be valuable, I hope, if you at least are aware of the reasons why somebody might think these sorts of things. I'm also going to, although this is a conference about health reform, I think that one thing I'm going to say somewhere in the middle of this talk actually would go away if health reform went away. If the current law is, in fact, I think today is the vote in Congress, if the Republicans in the House of Representatives are going to say, no, we want to repeal health reform, we're pretty sure that won't go anywhere besides the House of Representatives. But what if it did? What if this whole PPACA went away? There's one thing in what I'm about to tell you that would also go away. Everything else I'm about to tell you would still be here. The ethical issues that I'm going to discuss are going to be here no matter what our system is like for providing health care in the US. At least I'll make that claim. So it's only, but it is critical if health reform is going to succeed. We have to address these problems. If we make health reform go away, we didn't get rid of the problems. But if health reform is going to succeed, these problems will have to be addressed. So what I'm going to give you is what I hope is an ethical perspective. It's not legal, it's not policy. The interface, though, between ethics and policy is very blurry, I think, in this area. So a lot of what I say is going to be sort of at the borderline between ethics and policy. So the other thing I need to say by way of introduction is that in order to really bring the ethical questions home, we can't just put on our provider hats. A lot of people in the room here, and I think most of the people are providers. We also have to put on our patient hats. I think to see what's at stake here, we have to think of this not just as providers, we have to think of this as patients. So I'm going to sort of toggle back and forth a bit in this presentation, and I'll be talking a fair amount from a patient perspective rather than a provider perspective, and I hope that'll work out all right. It's going the wrong way. Okay, so the first part of this, I'm going to give you a case for discussion, and I want people to put on their patient hats. So stop being providers, start being patients. And we're not just any patient, but we're, like me, getting creaky, getting old, getting gray. All right? So one of the things you get when you get old and creaky and gray is you can get osteoarthritis, and knees are a common place you can get it. You've tried a lot of things for your creaky knees. They haven't worked as well as what you'd like. You've heard that your doctor has told you knee replacement surgery is down the road somewhere if you need it, but you don't want to go there quickly. You don't want to get new knees right off because of various complications. And you don't want a knee replacement surgery. That's like big major surgery, long rehab. You don't want that now anyway. A friend tells you about this miracle stuff. He had arthroscopic surgery for his osteoarthritis. And just a couple nicks, just a little regional anesthesia, and no big time surgery, but they did a scope, and he says he's a lot better. He thinks it's great. Very, very simple procedure. He says, this is great stuff. Why don't you go ask your doctor, as those ads on TV say. So you do ask your doctor. And your doctor says, I'm sorry, I really don't advise you to have this arthroscopic surgery. The reason I don't advise you to have this arthroscopic surgery is I don't think the best scientific evidence is in favor of it. I think the best scientific evidence today available strongly suggests that this kind of surgery doesn't work. So therefore, I'm afraid that I can't, in good conscience, recommend that you go ahead and have this procedure. My question to you is, what do you think about this? Your doctor has now told you this wonderful thing that your family, your friend said, why don't you go have this done? You go to your doctor says, nah, I don't recommend it. What do you think? I'm going to invite people to comment now. What do you think? You're the patient, you go to your doctor, what do you think about this?
I might want a second opinion.
You want a second, that's great, okay, you might want a second opinion. Excellent point.
Do research yourself on it and ask what scientific evidence is.
Great, you could ask your doctor, tell me more about the evidence. Where can I go myself find some research? Mayo Clinic newsletter, Harvard Health letters, good stuff on the web. There's a lot of garbage on the web, but there's really good stuff on the web too. And when I was doing practice, a lot of my patients who had to search the web, they came in with very good information. Any other thing? Comments?
I'd ask, what does doesn't work mean?
What does the, yeah, you want to know the details. What do you mean doesn't work? Because depending on the goal that you're trying to achieve, it might or might not work. So that's a good point. Get more clarification. Let's see. So there's a number of things you might think. All the comments were great, and these are all questions you could ask your physician. You might think, my physician's excellent. She bases her recommendations on scientific evidence. Isn't that what we want our doctors to do? You might think, I don't trust my physician. My physician is probably getting a bonus from the insurance company to keep costs down. So she's not looking out for me, she's looking out for the insurer. I don't know if I trust her. Okay? Or you might say, hey, my friend told me it works. Why shouldn't I have it too? He had it, why don't I get it? There's a lot of things you could think. Would it make a difference if instead of your regular physician, this physician was a specialist that you had no relationship with? First time you ever seen this doctor. Would that make a difference as to whether you trusted or didn't trust that physician's advice? Okay? Let me tell you about a hypothetical patient. This patient is a composite. I don't know any Harold Sanders, but or Saunders. We'll say this guy, we'll use this guy as a composite, all right? Harold Saunders is 67. And back in the mid-90s, this is a while ago, he enrolled in a research trial at the Houston VA. And this trial was a randomized comparison of that arthroscopic surgery for osteoarthritis of the knee. And basically, the people in this study were divided into 3 groups. Group number 1, they had the surgery the regular way, which is basically, I guess, like a sander, like whatever I do in a wood shop with a sander. They go in with some little, very small version of this through a scope, and they sand and fix up your cartilage in your knee, get all the rough edges off, make it nice and smooth in there. Okay? Takes about 45 minutes, I think, for the procedure. While they're doing the sanding, they wash water through it, so they do this lavage. And so group 2, just in case it was the lavage and not the sanding that really caused the improvement, group 2 gets the lavage only. All right? Group 3 is a placebo group. Group 3, they go to the operating room, they get nicks made in their skin, and the nicks are sewed up. They stay in the operating room for 45 minutes, and then they go out. They don't know that they haven't had the surgery because it's a single blind study, so none of the patients know which group they were assigned to, but they didn't get the surgery. Nothing was done in the knee joint itself. Okay? So like I say, single blind study. Mr. Saunders is explained. He could be assigned to any one of these 3 groups purely by chance. When he goes in the operating room, they're going to open the envelope and it'll have the magic number, which group he's in. And so he consents. He agrees. Passed the IRB approval. It's all legal and ethical with the IRB. And he says, yeah, I'll be in that study. I know I don't have to be. I'll volunteer. I'll be in this study. Okay? So what happens to Mr. Saunders? After surgery at 3 months and 6 months, he has a lot less pain in his knee and he has more mobility. He's very happy with the results. A video was done of Mr. Saunders before and after, and you could really see, if you watch the video, a change in his gait. I tried to go on YouTube and see if I could find one of these actual videos, but sorry, they don't seem to have saved them. So you could see him hobbling along before surgery, and you could see him striding across the room looking pretty darn good after surgery. Question: to which group was Mr. Saunders assigned? Do you think he was in the real surgery group? Do you think he was in the lavage-only group? Do you think he was in the sham surgery or placebo group? What do y'all think? How many people think he's in group 1, real surgery group? Raise your hands. How many people think he was in the lavage-only group? I see I haven't fooled anyone. You've all figured out that this guy was, in fact, assigned to the sham surgery group. Okay? The results of 2 studies that were done by Dr. Mosley at Houston VA both showed improvement in all groups, and they showed that real surgery was no better than sham. Lavage was good, sham was good, regular surgery is good, all equal. Okay? Basically, other studies have subsequently confirmed these findings, and this is the basis of your doctor's statement to you that there's no proof that arthroscopic surgery beats out placebo in terms of response of osteoarthritis of the knee joint. Okay? So that's why your doctors, because these subsequent studies, as well as the first study done in Houston, later backed up by additional large-scale randomized studies, shows these data that your doctor has relied on. Okay, so in this particular case, in the case of osteoarthritis of the knee, it turns out that the surgery in question, the arthroscopic surgery, could not beat out the placebo. So all we had to do was a placebo-controlled randomized trial in order to show that this surgery is not recommended for the average patient. However, here's the question. What if the surgery had been somewhat better than placebo? Maybe not a lot, but what if it was somewhat better than placebo? What kinds of studies do we need, we providers, not just physicians, need to make the best recommendations to patients in this kind of situation? Now, as most of the providers in the room already know, most of the studies we do nowadays in medical research are randomized, controlled, blinded studies with a placebo control. And if successful, they show that the treatment is better than nothing, the placebo. And it sets the lowest bar for the commercial interests that sell new drugs, devices, and procedures. Okay? So for example, the FDA typically requires that if a new drug is going to go on the market, all your drug company has to show is that it's better than placebo. They even will say if it's better than placebo in just 1 or 2 studies, that's good enough. If it's, you do 12 studies, and in 10 it's no better than placebo, and in 2 it is, we'll still go ahead and we'll approve it. Okay, so the commercial interests love this kind of trial because it sets the lowest possible bar for them to market their products. So from a purely financial business point of view, this is great stuff. Today there's rare studies that are of a different sort. These studies are what commonly get called head-to-head trials. And what they basically do is they take already approved treatments and they look at which of a couple different treatments for osteoarthritis of the knee or any other medical condition, how do they compare? They try to do these studies under real-world conditions, not so much in an experimental laboratory type setting or a medical center type setting, but if at all possible, as close as possible to community practice, to really tell us what the real world is like in terms of how these treatments function. And what is it? And so the question that they try to answer is, of the various existing treatment alternatives, which is best or which is better? Now, better could mean several things. Could mean most effective. Definitely makes your knees feel better. You can walk better, you're less pain in your knees. That would be one sense of better. Another sense of better is you get exactly the same benefit, but it's much safer. Fewer complications, fewer side effects. Okay? There's a third way something could be better. You get just the same benefit, it's just as safe, but it costs less. Is that better? Well, you saw on the previous slides how many things have copays. We saw how, the problem of the taxpayer, the US taxpayer, covering an awful lot of healthcare costs, increasing number of healthcare costs. If you saw that first graph and the lines in the different countries, you saw that in addition to the fact that the United States was at the very top in terms of total healthcare costs, you saw that at least half was taxpayer money. Okay, so if you are a US taxpayer, you have an interest in stuff not costing so much. If you are paying a copay, you have an interest in stuff not costing so much. If you want your insurance to be affordable next year, you don't want your employer to drop your insurance plan next year, you have an interest in it not costing so much. So you, the patient, I think, have a real interest in cost containment, among other things. Now, do you want cost containment at the expense of benefit and safety? Probably not. But if you can achieve benefit and safety at lower cost, are you interested? I would think maybe you might be. Those head-to-head studies are what is today increasingly being called comparative effectiveness research. And the one argument being made, and this is part of health reform, is that we need more of them. Comparative effectiveness research is hardly ever funded by commercial interests. Something like 75 or 80% of all drug studies, for example, are funded by, guess what, pharmaceutical companies. Pharmaceutical companies very seldom fund head-to-head research. They don't want to know, necessarily, if their drug could possibly be worse than some alternative drug. It is not in their interest. It turns out that we, the taxpayer, are almost for sure going to have to fund comparative effectiveness research if more of it is going to be done, and if we're going to have data on which treatment is actually best when they're compared directly against each other. Who favors comparative effectiveness research today? Government. It's in the health law. Some government anyway. Okay, so we saw that. Insurance companies like this, they would like to keep their own costs down. They maybe don't want to give it back to you, the consumer, but they sure want to keep their costs down, so they won't like it. People like me like it. Academic physicians who believe and are concerned about evidence-based medical practice, which we try today to teach all our students, we would like to have more data. We would like to know what is truly evidence-based. We want this kind of research to happen. We get some money in our own pockets if we do the research ourselves. We get a grant. So we'd like to see more grants to do this research, to generate useful data. Is anybody against comparative effectiveness research? Well, nobody is against this outright openly. How can you be against knowing what's best? How can you be against God, mother, apple pie, bear sleeping in the woods, etc.? Can't be against it, right? But there are some people who say, well, we're for it, but. We're for it, but. Don't let it get out of hand. Don't let it get out of control. We're worried about it. We got to be careful with this. This is a double-edged sword. So there's grudging acceptance among some groups. Let me give you an example. One example is a group called Partnership to Improve Patient Care. The head of this group is Tony Coelho, a former Democratic representative, House of Representatives. I think from California, I forget. Do you remember where he's from, Laura? Can't remember. It was set up in November 2008 specifically to lobby Congress around health reform. Here it was on their website back in 2009. I haven't looked lately. Somebody can go on the website with your little fancy phone and see if it's still there. But the mission statement in 2009 said, comparative effectiveness research can help us make good healthcare choices, but it is important to make sure this research isn't misused to make these decisions for us, is the way they put it. They're not so sure they're all in favor of this. Who are the members of this this group? Well, medical organizations are. One of the chief ones is American College of Cardiology. We'll come back to that. A number of patient advocacy groups are members. Things like American Diabetes Association, American Heart Association, those kinds of folks. And Pharmaceutical Research Manufacturers Association and other industry groups are also members of PIPEC, or PIPIC, or whatever that is. Who funds this? Where do they get their money? They got a lot of different folks who could kick in money. They could get it from American College of Cardiology. They can get it from patient advocacy groups. Where do they get their money? Some reporter went snooping, and what he found was almost exclusively this is drug company funded. That's where they get their money. Okay, so what have I tried to show you so far? What I've tried to show you so far, and I'll stop then and ask if there's, at this point, questions, challenges, rebuttals. Physicians, I would like to argue, need scientific research like and including comparative effectiveness research to know what treatments to recommend to our patients. If we want to do the very best for our patients, if providers generally, not just physicians, want to do what's best for your patients, our patients, we got to know what to tell them. How do we know what's best? We need a kind of research that directly addresses practical questions that we want answered. Personal experience is not enough, as with Mr. Harold Saunders and your friend who said, go get that arthroscopy. It's great. If the placebo group ends up doing just as well as the group that actually got the medicine, we can't rely on anecdote. We can't rely on clinical judgment to the extent that we always used to in the past. Okay? Advocates of reform at this point in time also advocate more comparative effectiveness research, including using it to cut costs, which we'll get to in our later part. And there are interests out there that are not quite so sure they like that, which we'll also talk about. Okay? Questions so far, off-site, on-site. If you ask a question here, please try to use that little microphone if you could, Jan. Is there a microphone you can talk into there? Thank you. Okay, the question was generalization. I don't think they heard. So the question is generalization from one trial. Super good question. A limit of any randomized trial, whether it's comparative effectiveness research or a more traditional placebo-controlled trial, it's always done on a certain population. That certain population may or may not represent your patient. When your patient walks in the door, they could be like or unlike the people on which the research was done. Any one study could be a fluke, and only if it's replicated. The reason I told you about the arthroscopic surgery is they started with a smaller group of veterans in Houston area. Okay, they got data that said no better. They then proceeded to do the same study at the same VA hospital, but with many more folks. No better. Subsequent to that, at least 2 large randomized trials have been done elsewhere. No better. Okay, so when you start piling up studies done different places with different populations, you start to get what you think might be an answer. You get one study, it's always questionable. So you always want to see multiple studies. And so comparative effectiveness research and evidence-based, what do I want to say? Evidence-based medicine is never let's tell you what one study is. Ideally, evidence-based medicine is how many studies have been done, were they done on the right populations that are really informative, and are there enough of them so we're starting to see a general trend. And even then, and as we'll talk about a little bit later, it may not be applicable to any one individual patient case. So it's always a huge question.
What I was really asking, though, Howard, is how much you can generalize to other kinds, from that experience, to other kinds of research like that, other kinds of...
Oh, I see. Okay. So that I misunderstood the question. The question had to do with this one case, like osteoarthritis of the knee. Can we say...
Other kinds of random...
Yeah. Okay, if I had more time and I wanted really to bore you, I could have trotted out numerous other examples. Okay, but, and I'll mention some as we go. But I gave you the one example in some detail because I wanted you to see the wrinkles in actually trying to figure this out. But if we had time, we could talk cardiology, we could talk GI, we could talk blood pressure, cholesterol, we could talk all kinds of things, and we could say we see the same kind of problem. It's a more general problem than just arthritis of the knee. Other questions? Yeah. Or comments or rebuttals?
On back to that one, the triple group design there. I mean, because placebo is a pretty powerful, treatment. And so by just saying in that case they thought they had the surgery, so they got whatever results they did. Can you really say it's no better than nothing? Because then you have to tell Harold or whatever his name is that, well, you're getting nothing. There's no placebo effect there. So if you compare those surgeries to whatever standard of care is, then I could see that then that would be a better argument in my mind.
Okay, that's the super question. Did everybody hear that? Was that audible offsite? Okay. Well, anyway, the question is, if a placebo is so darn good, and something is as good as placebo, doesn't that make it pretty darn good? Is that fair summary? Yeah. That's a really interesting question, And some of you are aware of a study that was very recently done that got a lot of publicity in the media where some folks were given placebos and they were told, oh, by the way, we're giving you placebos. And it turned out they still work. So shouldn't we be prescribing more placebos? Well, most people think that surgery, for example, does have some risks. It costs more than the average sugar pill does. And, there's complications of anesthesia, blah, blah, blah. So if we are going to give placebos, at least let's make sure we give safe placebos. Okay, and that's going to be one of the huge issues we're going to talk about here is when we talk about something like arthroscopic surgery, that people love it, but it doesn't work. They say it's great when they have it, but the statistics show it doesn't work. We also have to ask, and how safe is it, and are there a downside to it? If this is widely used in the population, are we putting people at risk? And are we sure that whatever it is we offer them is putting them at the least possible risk? Never no risk, but can we minimize the risk? Huge, huge issue. Okay, well, let's proceed then. All right, well, the special interests, as we said, there's a concern here. So what do they say to us when they don't want us to go here? They don't want us necessarily to find out that maybe some medicine is not as good as some other medicine if the pharmaceutical companies are funding the organization that has skeptical concerns about this comparative effectiveness research. The way I'm going to talk mostly about is they use the R word, rationing. Okay? I'm going to talk more about it. Is rationing a scare word so that when we hear the word rationing, we should scream and run? That's what they want us to do. And politicians today assume that it's a scare word. They never, never, never use the word rationing for what they're in favor of. Only time you'll ever hear a politician in the U.S. use the word rationing is if they're attacking somebody else's proposal. Is that a good, solid, rational, thoughtful use of the term rationing? I'll be spending most of my time talking about that. If they want to ratchet up a bit and the R word doesn't scare you enough, then it's the government getting between you and your doctor. And that's what, of course, PIPC was concerned about. Somebody will take these decisions away from you. So oppose comparative effectiveness research, maybe, if it threatens to take decisions away from you. And then finally, if you can't scare people with that, then you go to, you pull out the nuclear option and you go with death panels. Let's do the R word. What is rationing? Well, I think I didn't take Econ 101, but I think if I'd taken Econ 101, and if they talked about rationing in Econ 101, it would have said something like this. There's not enough of some resource to provide for all who want it when they want it. A resource is limited in comparison to the demand. And some system of distribution is needed to determine who gets to be first, either who gets the resource at all, or who gets to be first in line. How do we order access to this resource? I think that's fundamentally what rationing is. It basically is a way of saying we don't have enough for everybody right now. You're going to either have to stand in line, or somehow or other, we're going to have to decide who gets it and who doesn't. Okay? So I don't think that is a horribly scary or strange or extreme or radical kind of thing. I don't think it's a socialized thing. I think it's just like the way the real world mostly is. So not everybody can have a 52-inch diagonal flat screen TV. There aren't enough for everybody to have one. How do we ration them? You got the money, go buy one. That's how we ration 52-inch TVs. Okay, is that horrible? I don't think so. So what some people will say when they want to scare you is, oh, if we enact health reform, sooner or later there's going to be rationing of care in the United States. Or if you don't listen to me and if you listen to my opponent, sooner or later they're going to have to ration care in the United States. Well, do we ration care today? Yes, we do. First of all, we ration by ability to pay. You know, not insured. Or you don't have the money, you can't pay the copay, we ration care. We ration care a lot by who is your employer. If your employer has nice benefits, you get this really nice insurance package. If your employer, by chance, doesn't offer health benefits, you're out of luck. You could be doing the very same job, you could be just as good a worker, work just as hard, but if one employer has benefits, the other one doesn't, tough. So that's how we ration care today. What are the consequences of that? A lot of people said it doesn't matter because the only people in the US who lack insurance, they're the ones who are healthy anyway and it doesn't matter. So various studies have shown somewhere between 18,000 and 40,000 Americans die annually caused by their not having health insurance. So it does seem to matter. The way we ration care today in the United States kills people. That's the status quo. That's not what would happen if we had health reform. That's what is happening right now. Okay? Is there such a thing then as ethical rationing? If rationing is inevitable, because number one, we already do it. Number two, the only way to not have to do it would be to have an infinite set of health care resources. Or at least enough to meet everybody's need in the whole world. Now, today. MRI scanner on every street corner. Okay, not going to happen. So we're already rationing. The question then is not, should we ration? The question is not, oh, is rationing terrible? The question is there such a thing as ethical rationing of care? That's what I'm mostly going to talk about, because I think that's what's our challenge. If health reform or whatever we have instead of health reform is ever going to succeed, it'll be because we managed to contain cost. Because half the problem was what you saw in that first slide of Professor Hermer's, the fact that the US is so much bigger a line than all the other lines in all the other countries of the world, many of which have superior health outcomes to the US, right? That's only half the problem. The problem is how fast is that line growing every year? And everybody agrees, pretty much everybody agrees, it's growing so fast that it is now unsustainable. We cannot print enough money in the future to pay that much for health care, so something's going to have to give. All right? The question is, could it be done ethically? Is there an ethical way to ration care? I'm going to argue that there is such a thing as an ethical rationing system. And an ethical rationing system is fair and it's open. We know how it works. We know where we stand. It's transparent. And what's fair? There's a quick and dirty definition of what's fair. A lot of details, but the quick and dirty definition to sketch the big picture is this, I think. We'd agree on it ourselves when we're healthy to be in force, number one, when we're sick later, or when our loved ones are in need of care later. If we, when healthy, would agree to it freely for ourselves, knowing that we and our loved ones are going to fall under its provisions, I think it's fair. It's a kind of a democratic definition of fair rationing, if we would freely choose it ourselves. What might that look like? I would say the first thing we might do is care that provides no measurable benefit might be eliminated. Care with quotation marks provides no benefit, it isn't care, right? It's something, but it ain't care. So anything that provides no measurable benefit, but it costs money, how about we start there? Let's get rid of that. How about the next? Okay, so once we do that, we've saved a certain amount of money, but we haven't gone all that far. How do we go farther if we still have to save more money? How about then if we do that comparative effectiveness research, and we find out that there are two treatments that provide equal benefit and equal safety, but one costs more? Would we then agree for ourselves and our families, well, if they provide the same benefit and are equally safe, how about we take the cheaper one? We simply agree that the cheaper one's going to be the covered benefit and the more expensive one not. How about that? Would that be fair? If cost containment is in fact something we need to do, if we're all going to have health care in the future. Okay. The good news, I think, is this. Here's the good news. If we ration this way, based on existing data, we would have enough money saved that we could provide all Americans with truly beneficial care. I'll say a little more about that. Now, here's a comparison to what I think is unethical rationing, what just happened in Arizona, that you probably read about or heard about. Arizona said, Medicaid is out of control. We can't afford to pay for Medicaid. So let's take all those people who need expensive organ transplants who are on Medicaid, and let's say no organ transplant, because it costs so much. Well, it turns out organ transplants cost a lot. It also turns out whenever you look at organ transplants, they're reasonably beneficial. For the cost, you get a pretty darn good benefit. Okay? So people in Arizona, because they're poor, because they're Medicaid, are basically being denied a reasonably beneficial treatment because they don't have the cash in their own pocket. Is that fair rationing? Is that a plan you would agree to for yourself or for members of your family? I don't think it passes a fairness test. So that would be an example of what I take to be unethical rationing, by comparison to the rationing that focuses on degree of benefit and cost and starts working upward from no benefit, just a little benefit but costs too much, and then how far would you have to work up before you'd saved enough money to cover what we need in terms of health care for everybody. Okay? So the good news. If you read one book on this subject, read Shannon Brownlee's book, Overtreated, and I think she provides very, very good support, and I can give you other references if you want, that up to 1/3 of so-called care in the United States is unnecessary and non-beneficial. Okay? That would be roughly something like $800 billion a year. That would pay for all the costs of health reform. Professor Hermer gave us another option. The other option is that if we save that tax dollars that now go to the health benefits that you get from your employer that are not taxed. So if all of us were willing to pay income tax on what now we get without taxes, our health benefits from our employer, we'd also get $250 billion a year, and $250 billion a year would pay for health reform, I think. About? How politically likely is it that we're going to do that? I don't know. There's other ways. If we went to single payer, we'd save enough for pay for health reform. I don't think single payer is going anywhere soon. So there are other ways to get this money. The advantage of doing it this way is not only do we save money, we also get rid of that care, so-called care, that causes all those potential side effects in addition to costing us money. So patients are saved from unnecessary surgery, unnecessary procedures, unnecessary radiation. It actually benefits patients to not do this stuff. It's not just cost saving. The bad news, that's $800 billion. That's the good news. The bad news, it's $800 billion. $800 billion is a lot of money to now going into somebody's pocket. Those people who get that money in their pocket are not going to sit there, lie down when we say we're not going to do that anymore. Why do you think the American College of Cardiology is one of the big members of PIPC? If you read Shannon Brownlee's book, you see that cardiology is at roughly the top of the medical specialties where people think that an awful lot of their procedures, in fact, don't provide benefit. Okay? Do they want to know that? Do cardiologists want to be told that a third of what you do, by the way, doesn't help anybody? Are they going to sit still while some government bureaucrat says we're not going to pay for those procedures? Or are they going to tell you that's the government getting between you and your doctor? Okay? So they're going to fight hard, and they will try to scare us to be sure that we don't agree to what I would argue is a fair system of rationing, which happens to cut into their pocketbooks. Okay, so now we come to, we've been talking ethics. We've been talking about, is there such a thing as ethical rationing? So now let's talk about comparative effectiveness research. We've talked about the ethical benefits. We've said that if we did this research, we would know the answer, and if we knew the answer, we could be fair. We could pick the kind of things to focus on in our rationing scheme that we could take away without hurting anybody. We could save money without harming patients. Are there ethical questions? The ethical questions is basically what I thought Jan was asking, but turned out he wasn't asking. The ethical question is, does it pose ethical problems? It is because of, again, the problem of averages versus individuals. Comparative effectiveness research, like all randomized trials, is going to be about averages in the population. There are always going to be exceptions. In individual cases, the doctor might have good evidence that this is one of those exceptional patients who actually could benefit greatly from having this procedure, even if on average it doesn't seem to work. So I would argue that ideally a rationing system that incorporates CER, comparative effectiveness research, would have an appeals process, a very carefully developed and fair appeals process, and also I would go so far as to argue that there should be a special fund set aside for compassionate exceptions. There should be something like, I'm guessing, 1 or 2% of your budget for a health plan, Medicare or your private insurance or whatever, would simply be a set aside, and that would be available, and your physician or the individual patient could either appeal, and on successful appeal, that money would be freed up to pay for the procedure, which otherwise would not be the covered benefit. It would otherwise not be paid for because it's been decided to be not cost-effective, not beneficial. But if you were the exceptional case, we would say, we're going to treat you as an exception, and we have the special fund, so we'll pay. And obviously, that could be gamed. The money could run out at the beginning, before the end of the year. We could put too much money in it, and everybody appeals just to get them paid for. So there's all kinds of ways that could be gamed. There's all kinds of ways that might not work. But if it was done properly, I think it would be an administrative tool to assure fairness and compassion while still relying on the average statistics that we can get out of randomized trials, and that's all randomized trials could ever give us. So yes, there are ethical issues with comparative effectiveness research. If we had more time, I could talk about another big ethical issue. What does this do for health disparities? Are we sure that we have done the research enough on more vulnerable populations so we know that it isn't just white folks, for example? What about African Americans? Because if African Americans are not included in the trial, then can we say that this doesn't work for African Americans? So there's big issues around health disparities we'd also have to address. So yes, there are ethical problems with comparative effectiveness research. In my personal opinion, they don't invalidate the basic idea. I think they can be, I personally think they could be dealt with by various means, such as the appeals and the compassionate fund and so on. Others may disagree and may say, no, there's real ethical problems and maybe too serious. If you put together what I've been trying to suggest to you, I think it says, on behalf of us providers, we have an ethical duty. And I'm going to suggest a controversial way of thinking about our ethical duty. And then I'm going to turn that around and say, and what about us patients? What is our ethical responsibility as patients who are members of a society that have to all live together in this society? So first, let's start with the provider side. I think if you put everything together I said, you come up with this ethical set of responsibilities. I'm not sure that the law agrees with me. The law may differ at this point in saying that no, some of the things I tell you are not necessarily defensible if you're challenged by law, but then I would argue maybe that law needs to change if that's the case. I'm going to give you only an ethical argument for this view of our responsibility as providers. I would argue that our top ethical duty is to serve as an advocate for the health of the individual patient. Many would say, and that's it. Once I've said that, I've said all our ethical duties. That's what it's about. Pure and simple, period. Full stop. I disagree because of the problems we mentioned in terms of the inevitability of rationing, the inevitability of cost containment, or else nobody in the US is going to get health care someday. Okay? So I would want to argue that it's not enough to say just an advocate, although I would say first be an advocate. Difference between saying first do it and only do it. So next, I would say, after you serve as an advocate, you also have some responsibility as providers to serve as wise stewards of scarce healthcare resources. Now, I put here a brief comment, which is a lot of argument packed into a brief comment, but basically it goes like this. We could ration and have all rationing done and keep the doctor, the nurse, the PA, the provider completely out of it by having some kind of bureaucratic rules that ration care. It was said that this is what they did in Britain, for example, when they had an age cutoff for kidney machines or kidney transplants. They said anybody over the age of something or other, 70, 65, whatever it was, no kidney machine. That's an example of bureaucratic rule. If we wanted to implement what I said before, which is the kind of things we want to ration first are no benefit things, and the next thing we want to ration are virtually no benefit but very high cost, but there's something better, then somebody has to be involved in the rationing who actually knows the individual patient well enough to judge whether this is really a benefit or not for the individual patient. If we want that kind of fine-tuned rationing rather than a bureaucratic, across-the-board, boom kind of rationing, somehow health providers are going to have to be part of it, I would argue. And it's unavoidable, I think, that if we want that fine-tuned rationing, again, that it is somehow a burden on us providers to be a part of that. So let's go on and talk more about that. If the treatment is known to be beneficial, the ethical physician serves as you or the patient's advocate to obtain it. If necessary, going toe-to-toe with the government program or with the insurer, getting on the phone, talking to the medical director, talking to whoever controls the purse string, saying, I've got a patient who really needs this, they should have it, let me tell you why they're going to benefit. That's the duty the provider owes to the patient when the treatment is known to be substantially beneficial, or your clinical judgment says this is not one of those exceptions. This is a case where really, really, really there's a benefit. Or it is one of those exceptions if the guidelines say no benefit, but your patient is different. If good guidelines, which are based on real evidence, we could talk if you have any questions about how many guidelines today are based on real evidence. If good guidelines based on real evidence suggest treatment is not beneficial, but the individual clinical impression of you, the provider, suggests a potential benefit, then also you serve as an advocate. That's where that exception, appeals, compassionate care fund comes in, if it's a fair rationing system. Okay, so you still have a duty to advocate if you think this is an exception to the guidelines. Now, what happens though if the treatment has been shown to be either non-beneficial or no better than some cheaper treatment by good, well-designed comparative effectiveness research? Then, as a good provider, what do you do as the ethical provider? You inform the patient and encourage the patient to accept alternatives. You say, I'm really sorry, just like that doctor did in our hypothetical case at the beginning. The doctor says, I don't recommend that you have this. It has not been shown to be beneficial. It has not been shown to be better than something that's, in fact, cheaper. Okay? And if, despite the good evidence and the doctor's clinical judgment, you, the patient, still insist on a non-beneficial or unnecessarily costly treatment, you yourself have every right to go out there and try to get it. You can pay out of your own pocket. You can have a bake sale. You can fight the insurance company. You can take them to court. You can do all kinds of things. At that point, I would argue the duty of advocacy of your provider, though, essentially diminishes, if not ceases. They've done their ethical duty by telling you, in my opinion, in my best clinical judgment, I just don't think this is good for you. I would recommend you don't have it. And if you still want it, despite their best judgment and their reliance on good, solid evidence, I don't think they're being unethical if at that point they say, well, good luck to you, best wishes to you, but I am not going to advocate anymore for this. So I'm arguing that the duty of advocacy is limited by the duty to be a wise steward of scarce resources when you come to this point with your individual patient. Okay? Now I'm going to make an argument, turn that around and say, what does it mean for the patient? What does the ethical patient look like if this is the ethical provider? Okay? What does the good healthcare citizen look like? I'm going to argue that we as patients, under a system that is going to function in an ethical way, we would accept the reality of limited resources. When somebody says, oh, we may have to ration health care, your response is, so what else is new? Tell me something I don't know. Of course we have to ration health care. You would not be scared off by the mere word, oh, we don't have enough resources for everybody, for everything. You would take it for granted that's true. You would demand that the rationing system be fair and open. You would acknowledge the inevitability of some kind of rationing. So you say, we're going to do it, let's do it right. Let's do it ethically. Have a fair system, an open system. If you like my proposal, which is fair means it's what you'd vote for yourself for your own family, go ahead. If you've got a better proposal, put that out on the table. Tell us why it's better. Go for it. But whatever it is, we demand a fair and open system. As citizens, we demand this, we push for it, we advocate for it. We demand the compassionate exception policy. We know that scientific evidence always has rough edges, and at the rough edges there's individual exceptions. So we demand, as part of a fair plan, we allow for those exceptions. Okay? When our physician or our provider is acting in accord with these policies, we accept their recommendation. Do that research if you want to. Go online, check it out, ask those tough questions. And then if everything is that way, we should say we accept those recommendations, even if the answer is no. Even if I said, I'd really want that arthroscopic surgery, and they said, no, I don't recommend it. If they're doing it according with that fair policy, informed by good evidence, we should say, well, you've talked me into it. I guess I don't want that after all. And we would be aware that there's folks out there who have commercial interests, who have financial interests, who are going to try to scare us, going to try to stampede us, going to try to hook us to their wagon to get to promote their cause. And as good citizens, we will be skeptical. As good citizens, we will ask hard questions before we get roped into those causes. We will ask whether that really is promoting a fair system for everybody, or whether it's in fact some special interest trying to take care of their own. Okay? So that is what I would offer you as an overview of a problem that I think health reform, no health reform, whatever, as long as costs in the United States are going up at the rate they're going up, this is going to be the core ethical problem, either for health reform or for whatever we replace it with. Okay? Thank you very much, and I will open up for more questions and discussion as we go forward, okay? Off-site questions, comments? Anybody in the room here? Rebuttals. There's got to be somebody who disagrees with all this, so where are we getting here? Jan.
I don't disagree, but I want to come back now to the question we thought I was asking about the average patient. Let's say that I want to be a good patient and I want to accept my physician's recommendation. How will the physician know that I'm not an average patient? If in the current system, I might be more easily able to talk the physician into saying, well, this particular treatment has a small marginal chance of helping you, but since your insurance company will pay for it, or you can pay for it, or somebody will pay for it, I'll do it. Whereas in this kind of situation, that kind of case would arise very infrequently, I think.
Yeah, that's going to be a really, really hard question. And that's going to be very focused on the particular condition. But I think ultimately it's going to lie in the issue that we previously mentioned about the averages and about how representative is any particular sample that was used to generate the data that is relied on by the comparative effectiveness research. So if, for example, General, if there's like a recommendation of an age cutoff, to take a real simple example, and the evidence really shows that, boy, this procedure just doesn't work really well for people over 70. So we recommend that patients over 70 not get this procedure. And a patient comes in the door and you're the provider, and this patient is age 72, but they just look and act, and all their health history really suggests that they're much more like a 60-year-old than a 70-year-old, then that would be the indication in your case, this is an exceptional patient. Even though the age cutoff says 70, I think really they still qualify. Okay? So that would be a very straightforward and simple illustration. The other cases would be much more subtle in terms of the applications of a provider's clinical judgment that makes you think they're just different. So, for example, you could have a situation where this particular treatment is not recommended for patients with diabetes. And your patient has diabetes, but it's very, very well controlled, and they have no complications of diabetes. And so you think, you know, their diabetes is so mild, it shouldn't stand in the way of their benefiting. So it would be very, very fine-tuned kind of judgment, I think. But that's why I argue that ultimately we providers are going to have to be involved in rationing in one way or another if it's going to work, if we want that kind of non-bureaucratic, across-the-board, draconian kind of rationing that nobody over 70 gets this, bang, no exceptions. So it has to be involving the provider, I think. Laura.
Yes, just to preface, I agree. I believe that providers should have a social responsibility, but it's going to be very difficult to get providers on board. I mean, just putting aside all the medical malpractice issues, so we're bracketing that.
Yeah.
On the one hand, it may make sense with respect to Medicare and Medicaid. It's a public pot of money. But if you've got a patient who has, some a PPO plan, and you think that your patient is requesting a treatment that really isn't going to do them any good, and we'll put aside the question whether it's going to harm them, why not provide it to them? I'm playing devil's advocate. Why not provide it to them? Because that money is just going to go back in Aetna's pocket, or in the best scenario, it's going to benefit other Aetna beneficiaries, maybe. But we don't know that. We can't be sure.
That leads to a couple, I think, of very, very excellent points. First of all, I totally agree with you that if we're talking about going in this direction, we are really talking about, in many ways, a sea change. One person in medical ethics who's been saying the same thing, and you could say doing nothing more than parroting what Dan Callahan has been saying for at least, 3 decades now. He's been carrying on like this for some time, writing book after book after book, which is a variation of saying this. And basically what he says is we're talking a change in culture, and we're talking about maybe 20 years if we were successful. We're talking about changing the whole American culture. Right now, the American culture says if grandma goes to the hospital, and if the doctor says anything other than we're doing everything to save grandma's life, then you as a dutiful grandchild ought to beat the doctor, about the head and ears, and in punishment for daring to say you would do anything less than everything for grandma. That's what our culture tells us today. So we're talking about changing a culture so that guess what? It was more like Canada, or more like England, or more like Germany, or more like France, or more like all the other countries of the world that have, at one level or another, accepted this and don't have out-of-control healthcare costs like we do. They have some cost problems everywhere in the world, but they don't have the out-of-control crazy healthcare costs we do, because the population at some level has accepted the reality that there are limits. Okay? So we're talking about that kind of culture shift, and ultimately that's going to be decades, fully. And I don't want to put the malpractice stuff off to the side, really, because that's reality, and that is something that's going to have to be addressed. Will I get sued if I do this? The other thing, though, that you highlight that I think has been a terrible tragedy about the way we've gone about health reform is the Obama administration, I think, wrote off the providers. I think the Obama administration said, we're going to do this, and if we get the American Medical Association on board, we've heard from the providers. Well, sorry. I'm a physician. I'm not a member of the AMA. You didn't hear from me. And providers have been shut out of a lot of this process. If providers don't feel real ownership of this issue of appropriate, fair cost containment, and our responsibility as good providers to do this, including, again, the basic point, if we provide useless, non-beneficial treatments for our patient, we're exposing them to all the risks that are part of that. If I order that CT scan, which is not unnecessary, we're waking up today, we're counting how many excess cancers are caused in the United States by unneeded CT scans. So we are having to face, as providers, the harm we do to our patients when we refuse to take on this responsibility. So I think there's a variety of reasons why the administration really ought to have reached out farther to providers and tried to incorporate us and ask us, please be part of this. Please say how you would be a part of this because we need you. There's a famous quote from the fellow who was given credit for engineering the National Health Service in Britain, making the National Health Service in Britain be a reality after World War II, was a minister named Aneurin Bevan. And Aneurin Bevan was quoted at one point as when he said, how did you get the British Medical Association, which originally was staunchly opposed to the NHS, how did you get them to accept the NHS in the end? And Aneurin Bevan said, we stuffed their mouths with gold. They put so much money into physician reimbursement in the National Health Service, in the final version of it, that the doctors were bought off and they said, fine, we'll sign on. Now, is that the way to do it? Today, I don't think so, unfortunately. I wish it would, maybe wished it would, but it ain't. But the point was, Aneurin Bevan knew that if you didn't get the doctors on board, if you didn't get the providers on board, it wasn't going to work. The Obama administration failed to pass the Aneurin Bevan test so far. So I think there's real problems ahead to the extent that providers have not been made to feel part of this. That's one of my big worries about where we go from here. And I think there's one other thing you said that's really important, so don't let me forget it. And of course I forgot it because it's so important. You said something that I think is part and parcel of what's fair in terms of rationing, and I forget what your point was now. Right. The other thing about fairness is the recapturing of money that's saved. If the money that's saved by grandma not getting the care, if the money that's saved goes in the CEO of the insurance company's pocket, so instead of getting an $80 million bonus, he gets a $90 million bonus, not fair. The only fair system is where that money that is saved is reinvested and recaptured in care for the next patient who needs the care. Very good point. Other questions or other comments or other rebuttals? Please. Yeah.
I'm struggling a little bit with the
I'm sorry.
concept of, sorry, did I jump in?
You go ahead and then you're next.
Okay. Advocacy, and one definition would be an advocate, like a devil's advocate, is one who pleads the cause of another. And so I'm wondering, as a good patient citizen who accepts the need for setting limits and who exercises my right to autonomy, and along with it, my requirement to be responsible about the choices I make, and to consult my physician for the best available advice. In addition to changing the culture that Callahan and others are talking about, aren't we also changing the norm from one that says that the doctor's primary ethical duty is to place the best interests of the patient at the forefront and to provide care that's in that patient's best interest? Isn't that going to be changed to a norm that says the physician's ethical duty is to provide the best available medical advice based on evidence or the results of comparative effectiveness trials? And if so, how much does that compound the fact that right now physicians and other care providers have been either left out of the debate or are not joining?
Yeah. Okay, if I were to, if I understand the question, please get back to me if I don't seem like I'm answering the question. We have not, as well as we could have, articulated the ethical realities of this new physician role because it's been so unpopular among professional organizations to grapple with anything other than pure patient advocacy. It's very easy to say what the physician's ethical responsibility is, and you win lots and lots of brownie points with the general public when you declare that the physician is solely and 100% your advocate. That's it, period. If you try to say the physician is mostly and first your advocate, but then there's this other stuff, then it gets muddy and messy, and people don't want to hear that. And professional societies don't want to try to explain that to people, and they're worried about what the backlash might be, so they don't articulate that very well. So we have not heard all that well a clear, rational articulation of that set of ethical responsibilities that I'm sketching out. Okay? That's part of the problem in terms of us grappling with what does this really mean, is our need to sort of invent now what it is we mean by this. And it sounds different from what we've been hearing for all this period of time. So when we talk professionalism, for example, we talk both. We say, well, you should be scientifically based. You should really know your science. And you should, above all else, represent the interests of the patient. And we don't deal with, and what if, though, you can't do both at once, right? So it's very easy to have very high-sounding rhetoric about this, and unfortunately, the real world is a little bit messier. I still would want to argue that our advocacy duty remains kind of our defining piece of professional ethics. And it comes first because if we're talking about society as a whole and its need to conserve resources, and the individual patient who needs care, the individual patient who needs care is almost always the more vulnerable party. And we as physicians or providers, I think, ought to be concerned about the more vulnerable party first. So I'm going to stress the priority of the advocacy role, but I'm not going to use that as an excuse not to mention that there's this other role too, at the fringes. And with as much money as we're spending in healthcare in the US, it can be at the fringes. The number of things we'd ever have to say no to our patient to is relatively small as long as we're willing to spend, what is it now, 16, 17% of GDP? Where are we on?
We're moving to 18.
Going close to 18% of GDP, and the country hasn't shut down quite yet. So, you know, if we're willing to spend those kinds of bucks, there's a lot we can provide for people before we start saying no. If we were in a much poorer country, it would be much harder. The provider would be in a situation of saying, I know scientifically something would help you, there's just no way we can provide it for you here. You want to fly to Cleveland Clinic at your own expense, go for it. I can't help you. So I'd like to think that it's doable to articulate that new professional ethic, but it's a job that most people up till now have shied away from. You're next.
This might fall in the category of cultural shifts we're not ready for, but whenever I hear about cost savings and all that, and prevention isn't at the core of it, I'm a little skeptical. If I read one more article that exercise is good, healthy diet is good, obesity is bad, I'm going to gouge my eyes out. So you don't need comparative effectiveness for that, but I'd also argue that that would not only pay for health reform, but you could throw in a 52-inch TV for all of us if that was at the core of healthcare.
Yeah. Okay, that question, that is a great question about isn't the answer prevention. I would shift that one back to Professor Hermer because it's a policy question. There's a lot of data on the extent to which prevention would actually save money. And the answer is if you do it with newborns, it saves a ton of money. If you immunize kids, it saves a ton of money, all right? Almost all prevention on middle-aged folks adds to healthcare costs because people live longer, and if they live longer, they get more diseases because they're older. Okay, so the bad news is prevention doesn't save money. Prevention is wonderful for lots of reasons, but not because it saves money. So I think it's kind of a myth, unfortunately, that the way we save money is by prevention. Now, there are individual pieces of prevention that save a ton of money. There's all kinds of ways to take chronically ill people and prevent their going to the hospital. Right now, It's in very few people's financial interest that you do that, because if UTMB did it, for example, UTMB would lose money because we make a lot more money when we hospitalize people than when we do outpatient stuff. Okay? So if we change the incentives, what I think an accountable care organization is supposed to do, we could save a ton of money by preventing unneeded hospitalizations. Okay, so specific pieces of prevention work. We need a lot of comparative effectiveness research around that hated exercise and diet, right? Because the question for us providers is, we can talk a blue streak and nobody will do it. What provider interventions actually work? If we want people to get up and exercise a little bit, which intervention works? Where should we put our effort? Because why waste time and money talking to people if they're not going to do it, right? So there's a lot of need for comparative effectiveness research around prevention. There's targeted prevention that can save money. Most preventive medicine doesn't save money, in the middle-aged and elderly population especially. So that's an unfortunate reality that I think most people have not been informed of. Most people think prevention, oh wow, that's great. Other comments and rebuttals?
Are there any questions from the remote sites as well?
The remote sites have gone to sleep, Tony. They're not paying any.
There's one person.
I'd like to, well, first of all, when I put this idea together with the DC proposal back in April, and as ideas of special topics, I thought about tackling healthcare reform. I just have to thank Dr. Hunter and Dr. Brody, because this is exactly the kind of forum that I was hoping we could form, and the discussion is great. So thank you tremendously. I wanted to bring up just my own question, especially in terms of the countries that maybe in terms of socialized medicine. That we didn't talk a lot, but does it come with the waiting lines for care more or less? While we could improve better insurance coverage in terms of access to care, does it come under that? Will there be negative impact on the kinds of waiting for services that you might see in England or in France? Just very simple.
Okay, so a quick answer to that's a good question. There would probably be some areas, and hopefully it would, first of all, well, let me just say two things about that. Number one, the problem of waiting lists in France, England, Canada is way overblown. There's a lot of people who have a lot of financial interest in telling us that story. So those people can buy TV time, they can buy media space, they can get their message out very effectively. The people who really know what goes on the ground in those countries are not as good at getting the media attention, buying the media space. So we don't hear the good news about care. The fact of the matter is, if you ask people in France, people in England, people in Canada, people in the US, how many of you are very satisfied with your care? How many of you are sort of satisfied? How many of people are dissatisfied? People are generally very satisfied in those other countries. So the countries we hear horror stories about, the people who actually live there are generally pretty satisfied with their care. Okay? That's one point. The second point is that I think a lot depends on what you want access to first. So let me give you the example of the so-called primary care medical home. The primary care medical home is an idea that has been promoted as a twofer because it will, number one, improve quality of care by many, many measures, and number two, save money. So it seems like a win-win. You could actually save money by providing better care. One of the ways it provides better care and improves quality is better access. A primary care medical home designed the way it's supposed to, same-day appointments, easy internet access, easy email access to your doctor, easy phone access 24/7, hours that are more compatible with what the community wants instead of just open when the staff want to be open. If people want evening, weekend hours, it has it. So you could get quicker access to a place where you'd get care by people who know you best, and ultimately that leads to lower costs compared to going to the ER where they don't know you. So before they do anything, they run 20 tests because they don't know you and they don't know your history, and so they got to find out who you are, which means a CAT scan and a blood panel and blah, 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 and then they see you. In primary care medical home, they got your record, they know who you are, you just walk in and they see you. So it's potentially lower cost and higher quality. So there are some ways in which lowering costs could actually be compatible with improving access. And usually what saves money is not to keep people away from access and then we save money. It's smart access. It's access when they need it the most and when you can best get a handle on their problem, and you want them there then, because it costs more if you see them some other time. So I think the access problem is part of the engineering of a smart healthcare system, and it doesn't automatically follow that a cost control system will be one that denies people access.
I practiced medicine for 55 years. I was in a part-time faculty here and hospice-based here, but most of them across the street at St. Mary's Catholic Hospital. And ethics was never mentioned. You had to do that on your own. But one thing that helped me was the first time when Grandma came to the office, I insisted that some family member come in, and most of the time it was a daughter-in-law. And there you got to be acquainted, and you then talked a little bit about, you know, if some serious thing occurs, about how just to use reason or whatever, and so that's how I got a feel of what the family and the patient wanted. And so if some emergency came up, you were in a position to deal with it. And as I say, I was a strong captain of the ship. I did what was best for the patient. I never feared for malpractice. I never had a malpractice suit, and I never had a patient who died in the operating room or 24 hours after that. So that was kind of the way that I practiced.
Yeah. I think there's studies about what is it about the American healthcare system that, number one, it costs so much. Number two, we have so many medical errors. We have such a huge problem with medical errors. And where 10 years now of working really hard to reduce medical errors seems to have had so little payoff. And the answer keeps coming back: poor communication, poor coordination. The fact that patient care is now so fragmented, where so many more people are trying to get care and they're not talking to each other. And the good old days, if pardon the expression, of the physician who really knew the patient and the provider who was the hub of the patient's care, who knew the patient really well over time, had a good relationship from day one with the patient and the family that was so efficient. And we have introduced incredible inefficiency in today's healthcare system by going away from that model. So I applaud and honor what you say.